Not a problem. So welcome and thanks to everyone for joining the session. As you can see up there at the moment, my name is Reubenson. I'm one of the pediatricians here at Reubenson, London Child Hospital. So some of you may know me, but for those that I haven't met, welcome to the session. What we try and do is every 6 months or so we can have an exam overview so that the new people who join the group and who join the sessions can kind of have some understanding of what goes into the DCH exam itself. And so typically kind of January and July we'll do that. So that's what this session is. So some of you may have heard it before, others it's going to be the first time, but in essence it's just to kind of give people an understanding of what the exam is and how kind of we run the program here at Reubenson to get people ready for the exam. Just by maybe way of a show of hands, how many of you are actually writing this time around? And how many of you are planning either at some point in the future or just still haven't yet decided to write? Okay, so I can see one hand, that's two. Okay, so these people, so quite a lot of the people on the call here are actually writing in the next few weeks or so. Okay, good. And so for the rest of you, hopefully you'll plan it in the future. Okay, so what we do here is every Tuesday, it's usually Tuesday, occasionally it might need to change if the Tuesday isn't a convenient time for the allocated person, but most Tuesdays kind of from 2 to 3 p.m. we'll have a DCH session. We open it to whoever really wants to, whoever thinks they can get something out of it. Historically, it's generally been in person, so people have come here and we've had discussions either around a bedside for the clinical stations or, depending what station we're doing, the appropriate sort of setting. More recently, we've obviously moved to an online platform, and so that makes things a little bit easier for people to join if they're not based here, but obviously it does take something away from our ability to kind of interact with each other. But having said that, the exam was also moved to an online platform, so it does kind of prepare people for what they're going to experience in the actual exam. So what I'm going to do now is relatively quickly just move through an overview of the exam, kind of what it is, how it works, what the examiners are looking for, what the various stations entail, and then there should be quite a lot of time at the end for discussion if people have questions that they can pose. Okay, so the exam date, as those of you that are writing are probably aware, is fairly soon, and I'll ask you honest, this came as a little bit of a surprise to me when I was kind of drawing up the July allocations and noted that the writtens were fairly soon. I thought they we had a little more time before those, but having said that, that is the case, and they're going to be taking place on the 19th and 20th of July, so essentially 2 weeks from today. Regarding preparation for the written, we have one more session before that, so that's next week's session, and so that session is going to be on the written exams. And so what I encourage you to do, let's just check it, I think it's Dr. Tindemeier who's facilitating the session. He's quite an experienced DCH examiner, is to try and find some questions that you want to discuss, to, if possible, to share those questions with the rest of the group, either on the Teams platform or on the WhatsApp group, so that other people have a chance to read through the questions you want to discuss and can also kind of think about how they would respond to those questions. The session doesn't usually entail kind of what the right answers would be to any particular question. It's more about why is a question like this in the exam, what is the examiner looking for from people, so it kind of gives you just a kind of a higher level overview of the written process. If you don't prepare those questions for next week, it does make it a little more difficult for the tutor to kind of know what to do and how to kind of run that session without that sort of preparation. So if you are able to give it some thought and find some questions you want to discuss, it makes for a much better session when the writtens are being discussed. Right, so there are two main documents that provide background to the DCH exam, the regulations and the guidelines, and for reasons which we're still trying to understand is they've been changed on the website such that the regulations appear there, and the most recent version is there at the moment on the CMSA website is the March 2020 version, but the guidelines, which have always been there, don't seem to be appearing there at the moment. We have asked the college to put them back up, but as of this morning when I last checked, they weren't there. I don't think it's a major issue for you guys, but just to recognize that there are supposed to be 2 documents there, but much of what you need to know, much of what we're going to be covering here, is actually in the regulations. And to take a little bit out of the regulations, I suspect that most of you already know what you need to do to qualify for the exam. Certainly all of those of you that have registered for the exam will know. But essentially all that's required to enter the DCH exam, and we have consciously made it relatively easy to kind of qualify to write, because we do want people to be able to enter the exam. We do see the DCH as one of the ways that we can kind of equip healthcare workers across the country at fairly lower levels of care, so kind of non-tertiary, non-quaternary levels of care, to be able to understand and appropriately apply what they need to know for the care of children. So we don't want to make it an exam that's difficult to get into, but rather one that's open to most people who have an interest in caring for children, so that they're able to kind of acquire the knowledge and skills that they need to look after those patients. So essentially you need either 6 months of full-time training, which and your intern training, the 3 to 4 months of internship training, can count towards that under the direct supervision of a pediatrician. Or if you haven't been able to get the full 6 months under direct supervision, time under the kind of supervision of a district pediatrician or some sort of indirect or regional supervision is recognized, but it kind of counts half as much. So 2 months of that equates to one of the 6 months that's required to be allowed to enter the exam. You then need a letter from your supervisor confirming that you've got the necessary experience, and based on that you're then allowed to enter the exam. What I'm showing you here is just a essentially an old list, but just so you can kind of understand some of the background to the exam. So what we used to have in place was the council would accredit and list certain facilities at which training was recognized, but we've essentially moved away from that. And the reason for that is what we're looking for at a training site is almost the same as what HPCSA would be looking for from an intern training site. So we've kind of said that any facility that is accredited for intern training, we're happy with the experience people get there in pediatrics, certainly from the point of view of counting towards the DCH exam. In addition to that, the next thing you need to have is you have this form. It is part of those regulations. You need to complete the form, fill it out, and essentially get it signed by one of your supervisors, so that when the college are deciding whether you've met criteria to be allowed to enter the exam, that they've got the information they need. Most of the time it's pretty straightforward. When the CMS are not sure, they will then share those applications with members of the Council of Pediatricians, who will then go through those and decide whether the applicant meets our requirements or not. The regulations, which as I mentioned were updated last year, outline that the exam consists of 3 components. In our mind, it's really 2 components. It's the written component and the clinical component. The written component consists of 2 papers, both of which are 3-hour papers, and the first one is 20 data interpretation questions for 10 marks each, and the second one is 5 scenario-based questions for 40 marks each. I'll get on to a little bit later how these exams have been modified to take COVID into account. What I'm showing you now is it hasn't really changed. It's kind of minor tweaks, but essentially it's much the same as it would have been in the past, at least for the written component. And then there's the clinical component, which in the regulations is listed as an OSCE, or objective structured clinical examination, which has 6 stations. In order to pass, people need to get at least 50% for the written component, so the first 2 papers count equally. So provided you achieve at least 50% overall on those 2 papers, you then invited to the clinicals, and within the clinicals you need to get a pass mark in that. And I'll come on to that, because we've changed the system a little bit with respect to what you need to do to pass the clinical station. Essentially the same sort of thing. You need to get at least 50%, but in addition to that you need to achieve at least 18 judgment points. But I'll show you how the judgment point works towards the end of the presentation. The syllabus is, like many postgraduate exams, is not that tightly defined, but conceptually it would include anything that a junior doctor, medical officer, general practitioner would need to know to recognize and to show their competence in the care for children. It's not designed to test specialist level of knowledge. It's not designed to test knowledge outside of kind of general pediatrics. And the content largely focuses on what you're likely to be expected to deal with, either as a general practitioner who's seeing predominantly children, or so that's the outpatient sort of component, or another outpatient component if you're working in a pediatric outpatient department at a district hospital, or if you're kind of a medical officer within pretty much any of the hospitals within South Africa, the kind of things you need to know. And important in that is kind of what you need to know in order to be able to, for example, supervise interns, but also what you'll need to know to recognize where the limits of your knowledge and skill are, and so you know which patients need to be referred and when and how to refer them. Not really going to go through that. That's what you can see on the slide there is kind of a summary of the syllabus, but you can see it covers most of the sorts of things many of you are dealing with on a day-to-day basis around common and important childhood conditions, but including things more broadly like health surveillance, a good understanding of what normal physical and mental development entails, how to deal with issues in the perinatal and early postnatal period from a neonatal point of view, to be able to identify emergencies, stabilize patients, refer appropriately, but also kind of more broadly to consider the greater context of child health around aspects related to accidents and child abuse, development, grants, the medical legal framework, both within South Africa and a little more broadly around international aspects of child health. The exams themselves are blueprinted. So what that means is what you can kind of see here on the slide and on the next slide, it's just one slide, is what kind of needs to go into the exam and what the various components are that go into it and what the exam should cover. So it's not all that rigid. You can kind of see the percentages on the side there, that if you add up all of them, they get to more than 100%. But you can see that child health should make up at least 20% of the exam, and usually about a third of the exam. It can sometimes be slightly more than that. And most other things are included to some or other extent. The only other thing that has to be represented is neonatology. But all the other kind of things you can see there at the moment tend to be covered to some or other extent, but it's not absolutely essential that they're all there. But you can kind of see that it gives you that you're expected to be able to handle a fair amount of general pediatrics. The writtens, and I'm not really going to spend that much time on it. As I said, next week's session we'll do that. This is taken from one of those documents on the website, and you can kind of get a feel for how it works. So the date interpretation questions, this is one example of those. You can see how it adds up to 10 marks. I will kind of just say now that when we're working on the online platform, you will be doing the written papers at one of the college offices. I suspect for most of you guys on the call, it will be at the Joburg offices, but if there are any people here from outside Gauteng, hopefully you know where you need to be going. And while we're calling them writtens, they're not going to be handwritten on papers and then kind of distributed around the country to the markers. What's happened in the last short while is it's now an online system, so you'll have a screen, you'll have a keyboard, and the questions will be projected to you, and then you kind of get to answer them as in a short answer format directly into the computer. You'll be able to move backwards and forwards between questions, so don't worry about the navigation. It's relatively straightforward. What it has meant is that sometimes in the past there would have been fairly long questions asked, whereas the approach now is likely to be that no particular sub-question is likely to be more than about 5 marks or so. So each question, so as you can see here, so this question will have a whole lot of different sub-questions. So rather than being asked to write short notes for 10 marks on a particular topic, you'll have the 10-mark question broken up into 3, 4, 5 or whatever sub-questions, and then be able to answer those directly. And essentially much the same for the longer questions, the scenario-based questions. So while there will be 5 particular scenarios, they will all have a number of sub-questions, so that each of them is likely to be 1 to up to a maximum, I think, of about 5 marks. It's not that rigid. The examiners and the conveners have got some leeway as to how they set the papers, but they also have in mind how easy and difficult it's going to be to mark. And certainly it's a lot more difficult to mark essay-type questions on the online format, and also it's a lot more difficult to answer essay-type questions in that format. And so the college have taken that into account, and you can expect to have quite a lot of short answer questions. I'm not exactly sure on what they've done with respect to the timing, but the last I heard, people were allowed extra time, so more time. So let's say the paper would have taken you 2 hours to finish, because you're now required to type, and obviously different people's typing skills vary, but in general will take longer to type a particular response than it would take to write that. Extra time, that's kind of been built into the time allocations, so that you shouldn't find yourself under any more pressure to finish the exam than you would have if it were written. We've essentially covered that. So where can you get past papers from? And you're more than welcome to kind of use the resources, the people within the groups, within both the WhatsApp group and the Teams platform, to share past papers. But there are a few, I think about 6 on the CMSA website. Many people who've done the exam before will already have past papers and will be happy to share them. And I haven't checked recently, but certainly in the past, the University of Victoria and University of Cape Town websites, Department of Pediatric websites, did have past papers there. Those are often useful resources. But just to remember that scenarios change, approaches to different conditions change. So just because something was asked, and often you'll come across the marking memoranda. The marking memoranda, if the same question was to be asked now, might be very, very different. And also, as I kind of touched on, there's been a shift away from longer questions with kind of long answers to shorter questions, not going really about a paragraph or so at the very most. This is one example, one of the scenario-based questions that's been used in the past. And again, I think it's one of those from the college website, so you can kind of have a look at that in your own time. But you can kind of see how it'll work. Is you'll get a bit of information, you'll be asked some questions, you'll get a little more information, and you'll be asked other questions, and you kind of gradually work your way through the case until you can probably end up at the end with going through investigation and management, possibly considering the advocacy and medical legal aspects related to the cases, as you can kind of see there. Moving on to consider the clinical exams. So in general, there are 6 stations. All of them last 15 minutes. There is a 5-minute changeover between stations. So what that 5 minutes is, it allows you to go to finish the station you're at, to go to the next station, to read the information that's been provided outside of that station, to prepare what you need to do for that station in those 5 minutes. And then once you're ready, so you don't necessarily need to wait for the full 5 minutes to be up, but once you're ready, you're then able to go into the next station and start there. Just to emphasize something I said earlier, is kind of what is the kind of level of exams, or what do you need to be able to do to pass. And so the kind of mindset we encourage our examiners to take is that in order to pass the exam, candidates need to demonstrate they are competent doctors, kind of working at the district hospital medical officer level, or potentially in the private sector, seeing GPs. And the reason I put up the STGs there is because that's almost the identical mindset that is taken at national EML and STG level when they're putting together the standard treatment guidelines and essential medicines list. So not that examiners will go to those documents when they're setting questions, but certainly the kind of mindset is much the same. So when we're putting those guidelines together, we kind of think, okay, well, what does a medical officer working at a district hospital need to know in order to manage patients, to identify the pathology, to initiate treatment, and when would they refer? So it is a fairly useful resource. It's not a kind of useful factual resource. It's not meant to be a textbook, but it does give you some idea of the sorts of conditions that you're likely to know about, and give you some idea of what certainly management, and to a lesser extent investigation, you need to know. Just kind of staying with the clinical examination, I'm not entirely sure I'll put this slide in here, but this was kind of an instruction sheet that we used when we ran the exam here quite a while back, just so that you kind of know how it goes and how the rotation works. Just a word on the timing, and it's fairly intuitive, that there'll be a bell to start the station that indicates the start of the 5 minutes that you have to prepare for that station. After 5 minutes, another bell goes. So if you haven't yet gone into the station where the examiner is, you then need to do that at that point. You then have 10 minutes with, that takes you up to 50 minutes from the initial bell, where in the role player stations you'll be interacting with the role player exclusively, and in the clinical stations that'll be your kind of hands-on time with the patient. Another bell will go with, so after 15 minutes or 5 minutes left to go, to tell you an examiner that you need to kind of shift. So in the role play stations you shift to face-to-face questions with the examiner rather than with the role player, and in the clinical stations that will usually be where you kind of finished off with the hands-on clinical evaluation and you're discussing the case further with the examiner. So in general, what can you expect to come up in the clinical carousel? So resuscitation skills will almost always be assessed at some point. Basic hospital management, stabilization referral, legal and bioethical aspects as I've kind of touched on. All of those are the sorts of things you can expect to come up in various different places throughout the exam. And the non-patient stations, the kind of timing you can see there, but it's essentially what I've been through. What do you need to bring with you? So many of us are more comfortable with our own equipment, and if that's the case, it's certainly absolutely reasonable to take your own equipment with you. However, things like diagnostic sets and patella hammers, tape measures, those sorts of basic equipment will be provided at the examination center, but certainly you should bring your own pens, you should bring your own stethoscope, and if you're more comfortable with your own diagnostic set and particularly a patella hammer, it makes a lot of sense to bring those. But if for whatever reason you haven't, that sort of thing will be provided. The mark allocation I've kind of already touched on, the 2 written papers counting half and the clinical component counting half. Don't really need to worry too much about the rotation, but just kind of put the slide up here in case people aren't entirely sure how the rotations work. This is one that was taken from one set of exams we did quite a while back. So this is when all 6 stations were still on site in person, and you can see that there are potentially going to be rest stations depending on how many candidates need to be gotten through the carousel each time, so the one that you're going to find yourself on. But there aren't necessarily rest stations, so sometimes there will be and sometimes there won't. If there are, it really doesn't matter too much to you, but you'll have some time to rest and relax before the next station. Each person goes through all 6 of the stations in the kind of old format. In the newer format, the one that people are currently registered for, they'll go through 4 stations in person at the hospital, and come on to exactly how that works fairly soon, and then 2 online stations the following day. So those 4 will kind of work like this. So each person will go through all 4 stations. You're not necessarily going to be going through exactly the same stations as everyone else, because often we're running parallel circuits and things like that. but the non-patient-based stations will all be identical across the whole country. And that's important because we have to time it so that people arrive such and leave such that there's no way for communication to take place across the country and across the institution. Everyone does all the stations, but not necessarily in the same order, for obvious reasons. Okay, so to kind of spend a little more time on the clinical cases, the 3 clinical cases will almost always, it can sometimes be a little bit difficult, but will almost always include 3 different systems. So in a typical example, you'll have 1 abdominal case, 1 neuro case, 1 cardiac case, or you may have a respiratory case. Those will be the 4 main systems. Not always. So for example, sometimes there'll be a nutritional case, sometimes there can be a child with dysmorphology, and the case is around describing those features. Sometimes it's a child with less commonly but musculoskeletal pathology, but most of the time it's going to be 3 out of those kind of big 4 systems. So CVS, respiratory, neuro, and abdominal. They will largely include common pediatric problems. There may be more complicated cases in there, but don't be put off by that. You're only going to be expected to function and perform at a medical officer level. But if the patients have got good signs, even if the diagnosis might be more complicated, there may well be in exams. But don't be put out by that. You can do very, very well on cases that you have no idea what the actual diagnosis is, even when that's the situation after leaving the station. Listen carefully to the instructions. You've only got 10 minutes of hands-on examination time, and particularly for patients who've got pathology in more than one system, it's easy to become distracted and start evaluating aspects that weren't really meant to be part of that case. So your examiner will say to you, do a general examination relevant to the cardiovascular system, and then examine the child's heart. Okay, that means you don't need, if that's what they say, you then don't need to worry about the respiratory findings. You don't need to worry about the abdominal findings. Or they may say to you, do a cardiovascular examination, in which case you would then have to do a general examination relevant to the cardiovascular system, examine the precordium, but you may well be expected, depending on your findings, to, for example, also take the chest, because that's relevant to how you put your cardiac findings together. You may well be expected to palpate the liver, because again, that's going to help you put together your overall cardiovascular findings. So be careful to listen to the instructions the examiners are giving you. They're there to guide you in the right direction. They're not trying to trick you. They truly want you all to pass. But if you're kind of going off, and it can happen understandably in a stressful situation, but if you're going off in the wrong direction, they will try and bring you back. It's important to keep listening to them. You can expect to be asked some basic investigations and the sorts of things you're going to be coming across within your day-to-day situation. So basic laboratory results, basic radiology, and you can expect, it can be difficult, but depending on the actual structure of the station, but you can expect to be asked about management and which sort of cases and when you would refer that particular case to a higher level of care. This is the mark sheet that your examiners are going to be using for the clinical exams, so you can kind of see how it's laid out, where it's broken up into the conduct examination, actual clinical examination, and the discussion, and for each of those components the examiner chooses whether you passed, failed, clearly passed, as you can kind of see laid out there, and then they give an overall final mark, final grading as to whether they think you've clearly passed, or anything below that, and they give a final mark where 50 is considered the pass mark. Again, you don't need to worry too much about that. That's part of the instructions we give to our examiners. Okay, so now moving away from the clinical stations, and the first of the they're all clinical, but the non-patient-based stations to consider communication. You've seen the general structure, so you're going to get in those 5 minutes a little bit of information that you need to prepare for the station. When you're ready, you go in and you can start your interactions with the role player. In the kind of 2021 version of the exam, you will have those, the role player won't be in the room with you, you'll be on a Zoom call with the examiner and the role player and yourself. Depending on that particular examiner's kind of setup, sometimes the examiner will be in the room with sometimes the role player will be in the room with the examiner, and so you'll have a camera that's kind of on both of them, and they may kind of tilt the camera towards the role player initially, and then when your time with them's up, tilt it towards the examiner. Or if the role player is not in the same room as the examiner, you'll then have three of you are all on a Zoom call, and so you're kind of expected to interact as close to as you normally would with the role player, even in the online sort of platform. So you'll then have so those 10 minutes will essentially be face-to-face time with the role player. Towards the end of the 10 minutes, so kind of with 2 minutes to go, the examiner will often just let you know that you have 2 minutes left, and you can kind of start finishing off. And then for the last 5 minutes, the role player kind of either moves out of line of sight or turns their camera off if they're in a separate connection, and you then have that face-to-face discussion with the examiner. This is the mark sheet that's used for the communication station. Again, not that different to the one for the clinical station. These have also all been converted to electronic formats, so not that it really matters to you guys as candidates, but the examiners will be completing these online, so it all kind of ends up in the same spreadsheet with the local conveners, the overall conveners, and eventually the moderators. History taking station is much the same sort of setup as a communication station. So 5 minutes to prepare, 10 minutes face-to-face time with the role player, either in person, if in a kind of pre and post-COVID times, but for currently, the role player will be online with you, either in the same room as the examiner or as a separate person calling into the Zoom call, and exactly the same sort of thing. You're expected to take a history from them, and with around about 2 minutes of those 10 minutes to go, the examiner will let you know that you've got 2 minutes left, and you can kind of start finishing off. And then for the last 5 minutes, the role player kind of moves away, turns the camera off, whatever the story is, and you have face-to-face discussion time with the examiner. The mark sheet, as you can see there, again, much the same as the other ones, and again, converted to an online format for the examiners to be using these days. And finally, the skill station, and this is one where there's been a little bit of change. So the first time we ran the skill station on the Zoom platform was last year, and that was not in person. So for last year, there were 3 clinical stations which were in person, and the other 3 stations, the history taking, communication, skills, were done on the Zoom platform. And it was felt that it was kind of, for that one, we used a radiology skill session, but it's kind of difficult to come up with enough skill sessions that don't actually require observing someone truly doing a hands-on skill. And so for this last set of exams, it was converted rather to a 3 and 3 to a 4 and 2 breakups. The 3 clinical stations and skills were done in person around the country. However, it did prove a little difficult for local conveners to all have the same equipment in place everywhere around the country. And so it meant that the skill that was being assessed also actually wasn't really as much a hands-on skill as it would have been in the past. It was an ECG station about how and where to apply ECG leads, what normal ECG findings are, and to interpret some abnormal ECGs and to go through the management was the skill station in the most recent set of the exam. As far as I'm aware, the skill station will remain as part of the patient-based carousel. Again, the same skill station will be done around the country, and you can kind of think about what skills it's possible to offer everywhere at the same time in various sorts of settings around South Africa. So I've given you some examples there. Most sites will have mannequins, so it's reasonable to expect some sort of resuscitation skill. Most sites will have access to MDRs, urine dipsticks, peak flow meters, visual assessment charts, and those sorts of things. So it's almost like it was in the past, where pretty much everything could be offered, but with some limitations, so that at least the experience is as similar as it can be around the country. And there you can see the evaluation form for the skills, and again, same sorts of principles that are used with other ones. Okay, moving on to the marking of the clinical carousel. And you can see there that we've shifted, much like the Part 2 exam, to a judgment point process. So you get 3 points for each bare pass, 4 points if you get a clear pass, 2 points for a bare fail, and 1 for a clear fail. And I mean, I don't know that it's ever happened, but certainly we have the option for people who have an unacceptable level of performance. And that's really about rudeness or kind of aggressive behavior towards the child. So, as I say, the option's there for examiners, but I don't know that any examiners ever had to use that. So essentially, if you start playing around with the numbers, what you'll see is that you can compensate for a bare fail with a clear pass, but you need to, if you get a clear fail, so that's less than 45%. If you get a clear fail in a station, you're going to need 2 clear passes to compensate for that. So it can be done, but it becomes much more difficult the more bare and clear fails you have. And if you kind of add it up, you'll see that you need to get a total of 18 points to be successful in that component of the exam. So what's changed on the COVID? And I think most of the stuff I've probably already covered. So the written exams are going to be online at CMS offices, run over those 2 days, as we said right at the start of the presentation. The clinical exams are going to consist of the 3 patient-based and the 1 skill station. They'll be held around the country, all of them on the same day at essentially the same time, largely at central hospitals, and largely unchanged as I've kind of been through. And there will be local moderators. Again, I put that in there because that's a little different to how the Part 2 clinical carousel has been run, where we've had to use, or we've needed to use non-local moderators. But for the DCH exam, the moderators that will be there will largely be local moderators. And the role player stations the following day will be at the college offices around the country. The examiners will be joining virtually, and the moderators and role players will also be joining virtually, and almost certainly will stay on the Zoom platform. Okay, so that brings me to the end of what I had wanted to discuss with you, but please, there's still a fair amount of time if people have got questions or comments that they'd like addressed. Just put your hand up and I'll call on you. Anyone got questions I want to ask? Nothing? Can I give it a couple more seconds if I think of anything I want to ask. I have been recording the session, so I will I'll share the link to the recording on both the WhatsApp and the Teams groups later today if I get a chance, otherwise tomorrow, so that even for people who haven't been able to join, at least they can still access this if it's going to be useful for them. Okay, so if there are no questions, that's fine. We can bring the session to a close. And just a reminder that the session next week will be on writtens, and so please, if you've got past papers and you've got questions that you think it's worthwhile discussing, both because you are quite sure what the examiner was asking or how you would have answered the question, and it's probably true that other people had the same concerns. So then, just to share those questions on one of those platforms, just to help people prepare and get the most out of next week's session. We're not going to have a session during the actual week of the writtens, so 2 weeks from today, and then after that we'll kind of go back to the usual rotation where we kind of alternate between clinical cases and one of the non-patient based stations. For those of you who are at Reubenson, that the names of the tutors and what station is being covered that day is at the bottom of page 3 of our timetable. I will try and post those allocations on the WhatsApp group, but I do sometimes forget. So if people would like to know what they are, just put a message up there reminding me, and then I can put them there. But if that's all from everybody, then I'm going to stop the recording and end the session. Thanks for those of you that were able to join us.